Rashmi?
Hi, good evening, everybody, and welcome to this diet of Ask Me OSCE. Today, we are going to cover some of the most important yet neglected parts of OSCE. We are going to have OSCE on refraction, pharmacology, and instruments. And we are very happy that we have some great faculty who are joining us today, this evening. First, we are going to have OSCE on instruments, and that's going to be taken by Dr. Kulkarni. Dr. Kulkarni is joining us from Neeraj. And it's really a treat how Sir conducts his exam. He's a seasoned examiner, and his lectures and his exams are really a treat to watch. So, Dr. Kulkarni, I hand over the mic to you. Over to you, sir.
Okay.
Welcome, Dr. Kulkarni.
Yes. Can you see the screen, sir?
Yes.
Okay. So we are going to talk about the instruments just now. And then I will show you how we are going to conduct the things, not intimidating anybody, but probably it's going to be a lively session. Let's see that. Basically, just 2 or 3 introductory slides I will just start. See, normally ophthalmic instruments are made up of either carbon steel, stainless steel, or titanium. The general properties normally are the length is less than 14 centimeters because it has to be within the working length of a microscope to the eye. They have to be lighter in weight because of the finer things which we achieve by these instruments. And they need to be non-reflective to avoid any glare coming through the microscope. When you compare the material which is presented, we have 2 major material. One is steel, another is titanium. Normally, steel is better for cutting instruments like scissors because it can hold a sharp edge, but it is prone to corrosion. Even if we say stainless steel, it is stainless and not stain free, but they are cheaper. Obviously, their lifespan is shorter. And in titanium, they are lighter, but they are more durable. They are non-magnetic, they resist corrosion, the hardness is much greater, and they have a low thermal conductivity. The sterilization of these instruments, normally they are cleaned by distilled water, that is important. And then we have to use ultrasonic cleaner, which will prevent the blood or debris from drying on the surface. They are normally sterilized either by autoclaving, by ETO, by formalin, or by gamma radiation. Now, these slides are actually there to help you out in case supposing you get slight block and don't remember all the points about the instrument, you can start talking about their material and their sterilization and other things. That will probably give you slightly more time with the examiner. Now, our point of this OSCE is that, okay, take all the participants, take a paper and pen. We are showing you slides with only 2 questions each. Every slide will carry 2 marks. Just write the question number, that is question number 1, 2, whatever it is. We will show you the slide for about 30 seconds and the answer key will follow after 30 seconds. There will be some details about that instrument apart from these 2 questions. So let us see how the things go. I will show you one example how we are going to conduct it. Supposing this is a slide which asks you 2 questions. One is name of the instrument and another is what is the special features. The answer would be the name of the instruments is Baracker's lead speculums, and special features are that it is lightweight and does not transmit pressure over the eye. In addition, we can have for MS and YY exams and other things, you should know that it is used for visualization and surgical procedures like cataract and glaucoma. It is used to retract the lids and hold the eye open for squint and pterygium surgery. It is self-retaining for removal of foreign bodies or carbolic cauterization. It is used in examination of the eye in blepharospasm. and then it is made of steel and sterilized by autoclaving. So these are the additional points on which either the questions can be asked or you can remember them for talking in your table viva. So should we now proceed, right? So all the best for the participants. What I want is that all the participants, you write down the answers. After 10 slides, we will stop, ask you who has scored the best one. You can just volunteer, and then we will say good show and proceed to the next slides. This has got a limitation of interactiveness because instruments, there is nothing much as far as the academics is concerned. So your question number 1 starts now. And this is the answer. So name of the instrument is St. Martin's tooth forceps. Advantage is it has got a non-crushing fine tips. In addition, we will have this information that it is 1/2 tooth. It has got a firm grip because of a serrated handle. This is the serrated handle. And there are platforms you can see near the end. It helps in holding and tying the sutures. And this has got a spring action because of its design. Comes the OSCE number 2. My stopwatch is not working, so you can just tell me in between in case I'm overshooting the time. So name of the instrument is Aruga's needle holder. Is used for bridle suture. The Aruga's needle holder is a sturdy and large holder used for thicker needles, like for superior rectus suture or stay suture. By the way, bridle is the one which is used when you pass the thread through the horse's nose and you pull it. So the horse's mouth goes downwards. That's why it is called as a bridle suture. It's a locking mechanism is present in these cases over here. You can see. And there is a serrated tip. So it does not allow the needle to rotate inside. So it doesn't allow it to slip. The other modifications are Cart needle holder and Silcox needle holder. We come down to the next one. So used in which surgery and advantages of the spatial tip which is being shown here. So it's used in ICCE, that is intracapsular cataract surgery, or used to be used. Advantages of the spatial tip is that it accommodates the anterior capsule in the cup, and that's how it prevents the tear of the anterior capsule. In addition, we have a posterior apposition and anterior, there is a gap in the Aruga's forceps. So this gap does not allow the iris to get caught. That's why it prevents the iris damage. This tip curvature is basically to adjust the anterior chamber depth. Now it's a limited use because of ECC, SICS, and Phacos. And remember that it is not recommended for subluxated cataract or lens dislocation, because in that case, you will be actually approaching the vitreous when you try to catch it. Go to question number 4.
Entropion led thing.
So name of the instrument is Snellen Entropion clamp. And advantages in the surgery is that it is self-retaining and gives rise to hemostasis. Now remember students, in case these common instruments have a name on which it is known, for getting a full mark, you need to write the names also. You can't simply say that Entropion clamp. You can talk about right side, left side, that's a different matter. The additional advantages of this clamp is that it protects the eyeball. It supports the lid so that surgery becomes easier. Only problem is sometimes the operative field is restricted for your surgery, and the hemostasis sometimes can lead to necrosis of the lid. That is to be remembered. Question number 5. In which surgeries it is used and what is the modification available? So it's used in ICC and ECC surgeries. ICC for the complete lens, ECC for removal of the nucleus. Modification available is called as irrigating vectors. So you have multiple holes here and you can get a fluid which comes and the flow comes out from the tip. This is a wire vectis usually used for removal of subluxated and dislocated lens. It is used for removal of nucleus in ECC. This is a thin loop which is necessary to pass between the posterior capsule and the nucleus when you want to take out the nucleus by depressing on the posterior lip of the wound. A irrigating vectis is usually used for what is called as a hydroexpression of nucleus. Most of the time we do what is called a viscoexpression, but even this is a very good method of removing the nucleus in a ECC case or SICS. Question number 6. Name of the instrument is LIMS tooth forceps. Method of sterilization is by autoclaving at 15 pounds pressure at 121 degrees centigrade. LIMS tooth forceps has a non-crushing fine 1/tooth forceps. The curvature is for better visualization through the microscope, so your hand doesn't come into the view. And this particular serrations are for good grip on the cornea as well as the scleral edges. Question number 7. The instrument is used for what purpose and what is the material? So it's used for injecting the foldable IOLs, and the material is titanium. The IOL injectors are normally used for hydrophobic foldable IOLs. This is a push type. A screw type is also available, and this is used with micro-incision cataract surgery. Question number 8. The name of the instrument is Colibri corneoscleral forceps. See the difference in the curvature than the limbs forceps. That is how it differentiates itself, and the special design. This design gives you a better field availability under microscope. This is a non-crushing tooth tips again. It usually gets a good hold on corneal and scleral edges. Used in cataract surgery, glaucoma surgery for the scleral flaps, corneal or scleral tears for their suturing purposes, and you can go on adding the list in case it is required. Question number 9. Name of the instrument and advantage of its use. Name of the instrument is Akahoshi pre-chopper, sorry. Advantage of its use is that it reduces the ultrasound energy requirement for chopping purposes or chopping the nucleus during phacoemulsification. This reduces the energy due to chopping and preparation of small pieces of nucleus. That's why the total time requirement, what we call it as a EPT or CDE, is reduced because of the use of this instrument. And this obviously reduces the incidence of wound burn and fish mouthing, which is possible because of excessive energy which is used. The question number 10. It's a capsule polisher. The use in surgery is for polishing the capsule. The advantage in postoperative period is that it reduces the rate of posterior capsular opacification as well as reduces the tendency for capsular phimosis, particularly when you have a smaller rhexis which has been performed. This actually physically removes the epithelial cells capable of forming the new lens fibers. As you are aware that these continue to produce fibers throughout the life of the patient. The intercapsule polishing around the rhexis margin also reduces the post-op opaque ring, which will facilitate the fundus examination for the VR surgeons or even for us. And the overlapping of rhexis margin on IOL and sharp edge of IOL are the two additional points which reduce the posterior capsular opacification. So we have a slight stop here, and I want the panelists, the students, to tell me who has scored which numbers.
So I'll request all the hot seaters to unmute yourself and unmute your video also so that we can see and you can tell your marks accordingly.
Sir, can you repeat the marking system, sir?
Marking system was two marks per slide.
So we have 20 marks total, 2 per slide.
10 slides.
Okay, so we'll start with Akshay. Yeah, Akshay, you can start.
Yes, ma'am. Ma'am, I scored 12 marks.
12.
Okay, good. Priyanka?
Ma'am, I scored 13.
13. Then Sonali.
Sir, I scored 13.
13.
Good. Zakia? Zakia, unmute yourself, please.
Yeah, I scored 14.
Good.
Okay.
Very good.
Then
1 second, sir. Yeah, Arnav. Arnav, please unmute yourself. Arnav, are you there?
Vineet also is there. I think Vineet also was answering.
Yeah, Vineet, you can go ahead.
10 marks.
10. Okay. Diksha, unmute yourself.
I was a little late to join.
Okay. Still, you can say how much you
Two
have.
questions correctly out of the last 4.
Diksha,
Okay.
you can tell me out of how many you scared how much. That is fine.
Last 4 questions, 2 were correct.
In last 4 questions, you scored 2 marks.
2,
2 out of 8. Okay.
Arnav, are you there? You can unmute and tell your answer. Arnav? I think he's not there.
Okay.
Yes, sir.
So what I was thinking was that we are asking too many undergraduate questions. But if you are scoring between 10 to 14, I think we may be slightly on the right track. Anyway, should we proceed, Rashmin sir? Is that okay?
Yes, sir. Yes, sir. Perfect.
Sure. Thank you. Coming up, question number 11. So name of the instrument is Vannas scissors. Special use in cutting anterior capsule. Vannas scissors you can describe as having thin handle and small blades. It's usually anterior capsule is cut in case of rhexis extension. It is also used to enlarge the small rhexis, and it can also be used to cut fine sutures. Fine sutures can be cut either by this or by simply a needle. Number 12. Name of the instrument is iris claw lens holding forceps. Indication is for implantation of iris claw IOLs. If many of you have missed it, that means you are working under a very nice boss who doesn't have PC rent or anterior capsule extension. So this is required in secondary implantation in aphakic eyes, as well as emergency IOL on the table when you are faced with PC rent and anterior capsule extension. Remember, if anterior capsule is not intact or the rhexis, the sulcus fixated lens is also not indicated. Question 13. The indication is for syringing, probing, or dacrocystography. What is lacrimal papilla? It is the elevation on medial end of the lid margin where the punctal opening is situated. This actually is a nettle-ship punctum dilator used to dilate the punctum with a narrow but blunt end. Otherwise, it will injure the canaliculus. It's also used before inserting lacrimal plugs in cases of dry eye. And it is also used in punctal stenosis to dilate the punctal opening. Number 1414. Name of the instrument is Sinskey hook, also called as Sinskey IOL dialer. Primary use, as the name suggests, is for positioning a non-foldable IOL in bag where you can put it into the hole of that particular IOL and turn it. Other uses, it can be used for manipulation or rotation of nucleus after the hydrodissection and hydrodelination has been done. This is also used for pushing the optic haptic junction for in the back placement, even for a foldable IOLs. And this is also used for iris retraction when you want to do a surgery in small pupil in case you are not using iris hooks or capsular hooks for dilating the pupil. Number 15. Method of phaco surgery, stop and chop, because this is a chopper. You can use it in stop and chop, or you can use in a direct chop. Direct chop can be a Nagahara chops, or it can be a 5/4 technique of vertical chopping. Contraindications, obviously, for a soft cataract with only grade 1 nucleus, because you cannot chop these soft cataracts. You need what is called as a spring technique or sequential pulsed removal of an inner nuclear girdle. The chopper is having a blunt tip and a sharp inner edge when you want to do a horizontal chopping. It reduces the phaco energy requirement by making the pieces smaller. Question number 16. Is used at what stage of surgery? It is used for cortex aspiration after nucleus delivery. Advantage is that it maintains the anterior chamber because on one side the fluid goes inside and you are removing the cortex, so the AC does not collapse. This is a Simcoe's irrigation aspiration cannula. You have an irrigation from central port and aspiration from side opening. Reverse Simcoe obviously is more commonly used, and this is useful when an automated IS system is not available. So it's more commonly used with SICS. Number 17. The sizes available for this bone punch are 1, 1.5 and 3 millimeter. It is used for enlarging the bony opening during dacryocystorynostomy surgery. This is a Cittelige bone punch. This is introduced through lamina papyracea and it punches the frontal portion of maxilla and maxillary portion of frontal bone to create an opening which should be at least more than 10 millimeters for the DCR to work. Number 18. Name of the instrument is Bauman's nasolacrimal probe. Now remember, you have to write down the full name. You can't simply say lacrimal probe when you are answering. Indications of its use is probing in congenital dacryocystitis. This is a set of various thickness of tips from 60 to 2, that is 1 and 2. There are blunt rounded end which prevents fall passage and injury to the canaliculus or the duct. And this is used also for identifying the sac during dacryocystectomy or dacryocystorhinostomy. Number 19. The indications of use of this is for penetrating and lamellar keratoplasty. The contraindication for use of larger size is because in case you take it larger, it is too close to the limbus. And because of the encroachment of the limbal vessels, the graft fails. So graft failure is one of the reasons you don't use a large size trephines. This is a Castroviejo corneal trephine, available in different sizes between 6 to 9.5 millimeters in 0.25 millimeter steps. Remember, the donor graft size is always 0.5 millimeter larger than the recipient. The vacuum trephines usually are now more common and they are disposable also. They prevent iris injury so that it doesn't go through and through. It's also used in therapeutic as well as tectonic keratoplasty. Question number 20. Name of the instrument is strabismus hook, used in surgeries for squint as well as for enucleation for hooking the extraocular muscles. This is used to pass under the muscle belly. That's why it is blunt. There is no sharp edge associated with this. And length of this tip corresponds to the muscle breadth. That's why the muscle doesn't get crowded. Usually it has to be at least about 10 millimeters. The blunt tip prevents a scleral injury when you are trying to pass it under the muscle belly. This is also used to assist in a detachment surgery when you have to hook the muscles before the surgery. So we stop here. We take a stock of how many marks have been scored.
Yes, sir. We'll go ahead. So Akshay, please unmute yourself and tell us. Akshay?
Yes, ma'am.
Yeah.
I have scored scored 13, ma'am.
Your voice is completely breaking. Can you just repeat once more?
I have 11 marks out of 16. 8 questions last. So I scored 11.
It's not clear, Akshay. Okay, in the meanwhile, we'll go to Vineet. How much you have scored?
17, ma'am.
Okay, great. Zakira? Zakira?
16.
Okay, good. Diksha?
15, ma'am. 1-5.
Good. Muskan?
Ma'am, 12.
Okay. Prithvi?
10.
Prithvi?
16, ma'am. 16.
Good. Priyanka?
17, ma'am.
Whoa. Vijay? Vijay?
Sonali,
Sonali?
Ma'am, 16.
Good. Shubhadra?
8, ma'am.
Okay. Akshay, are you there?
Ma'am, 17.
Great. So, sir, this time we have they have just climbed up the mountain.
picked up it nicely. Before we go to the next set of slides, are there any questions? Because I don't want to impose on other consultants' time later. So there are questions we can answer, or we can answer it after the next set is over.
No, sir, till now we don't have questions in any stream.
Okay, fine. We'll proceed, madam. Sure.
Yes, sir.
So 21. So name of the instrument is Burke's Ptosis clamp. Name of the surgery in which it is used is levator palpebrae superioris resection. It has got long tips with serrations. See, there are vertical serrations that does not allow the muscle to get slipped, and it holds the levator muscle properly for its advancement as well as for resection. It has got a locking mechanism that will also help us in avoiding the slippage of the muscle fibers. 22. This should be very simple. Name of the instrument is Castrovizio Ophthalmic caliper. The use is used in measurements during surgeries for glaucoma, for squint, for keratoplasty, for ptosis, and you name other conditions which you can remember. Basically, it is also used for measuring corneal diameter as well as visible iris diameter. Remember, wide to wide diameters, which is required for implantable collamer lenses, is not done by this instrument because this is a crude instrument. What you require is a different type of industrial ophthalmic caliper for that purpose. This is also used for measuring incision in pars plana vitrectomy, for giving intravitreal injections, and for detachment surgeries for the muscles which are to be marked over there. It carries between 0 to 20 millimeter on its scale. Number 23. This is an enucleation spoon. Indication is to engage and guard the optic nerve during enucleation surgery. Basically, it guards the eyeball rather than the optic nerve because we are going to cut the optic nerve as such. The central cleavage, this is the one which surrounds the optic nerve to guide the excision level. And the concavity of this fits the convexity of the globe. So normally the spoon is kept flush to the globe, excepting in retinoblastoma cases where you need to have at least 10 millimeter of stump of the nerve which is needed before you cut that optic nerve. Number 24. This is DeWaker scissors. If you are asked about the instrument, the D has to be small. It's a name, so you can't play with that. And it is used for peripheral iridectomy, or it used to be used. Nowadays, it's not very commonly used. This is the speciality, is that it has got very small blades and they are right angles to the body. There is a spring action which is there, so it is clean iris cut is possible with this. This was also used for cutting the prolapsed vitreous when we used to do CAM surgeries. And then there is a special grip here which facilitates a fine movements, because you don't want the cutting to drag on the iris. It has to be a very clean cut. 25. So the name of the instrument is Mueller's self-retaining retractor. Advantage of its use is it is self-retaining and hemostatic. This has got curved jaws. You can see here, there are curved jaws which engage and retract the skin and muscle when we are trying to operate on a dacrocystectomy or dacrocystorhinostomy. And because it is self-retaining, your assistant's hand is free to use your vacuum for taking out the blood which is coming. The retraction is fixed by this screw so that the opening remains constant for our surgery. 26. This is a side port entry blade, and method of sterilization, frankly speaking, they are disposable, but sometimes they can be re-sterilized by ETO. It's never autoclaved. This is a straight knife with sharp point and cutting on one side only. This is also called as a lance tip, 15-degree lance tip knife. And this makes a small valvular corneal incision in Phaco, as well as whenever you want to apply iris hooks or capsular hooks, or in a pars plana vitrectomy. 27. This is the instrument called as crescent knife, and used in surgeries for making a tunnel incision, either in Phaco surgery or manual SICS surgery. This has got a bevel up knife, which has got side cutting edges as well as cutting at the tip. And this can be used in scleral splitting incision, either for trabeculectomy or even for SFIOL when you want to take a scleral pockets. Number 28. The name of the surgery is incision and curettage of Chalazion. Never use the word excision, incision and curettage. Site of the incision used is vertical on conjunctiva and horizontal on skin. Vertical to avoid cutting of the meibomian gland ducts. Horizontal on skin to avoid cutting of the orbicularis oculi muscle as well as skin. So it's a hemostatic. The hollow ring usually is placed on the conjunctiva, and this, as I already mentioned, the horizontal incision also avoids cutting of the vascular arches, which are about 3 millimeter from the lid margins. 29, we come to the last but one slide. So name of the instrument is Utrata Capsulorhexis Forceps. Indication is for performing curvilinear central rhexis before the cataract surgery, whether it is SICS or whether it is Phaco. There is a sharp bend at the tip here, which can initiate the rhexis by just putting on the anterior capsule, and the long tip enables the reach for circular opening throughout the anterior chamber. The sleek end normally is that when you are passing through the main incision, then the escape of visco is to be avoided and the anterior chamber can be maintained. That's why you have these sleek ends. The last slide, number 30. The name of the instrument is Rycroft cannula. The various uses include the air injection into the anterior chamber, side pore hydration after the surgery is over, or anterior chamber wash either during surgery or even patients who have hypema. The specialty is that it is 45 degrees angled cannula. Comes in different gauges. What we normally use ranges from 20 gauge to 27 gauge. 27 obviously is smaller one, 20 is a bigger one. Is also used for drug injection in the anterior chamber. Whenever you want to use either a preservative-free pilocarpine, we used to use it for ICL surgeries. Nowadays we stopped doing it. The antibiotics, more commonly, many people use it as a moxifloxacin to be used after the surgery. Adrenaline, which also should be used very cautiously, but sometimes for dilating the pupils, and lignocaine, that is just to anesthetize the iris surface when you are doing a topical anesthesia. So we come to an end for this. I would like to know the score and let's see who has scored better. Before we go to the scores till they are calculating, I would like to thank Dr. Ashmin and Dr. Santosh Onawar. I have a very deep and great respect about these two academicians. I heard their lectures. We have personally met even in my institute and elsewhere also. And I hope this kind of programs which they are trying to conduct requires a lot of work and a lot of efforts. It's kudos to their efforts for the students. It's true to our heart as a teachers that whatever we do for the students usually is something which gives us much solace as well as much satisfaction. So thank you, Dr. Ashmin and Dr. Santosh, for this opportunity given to me in interacting with people.
Thank you very much.
Dr. Ankita, please.
I learned a lot. I'd forgotten cataract instruments totally.
No, that is how the great people are, sir. Your humility is something which has to be appreciated.
Cataract to karte nahi na sir, bhul gaya.
That is true.
Okay, sir, there are two questions for you.
Yes.
The first one is, what is modified Simcoe's cannula?
It's not modified Simcoe, it is called the reverse Simcoe. Reverse Simcoe means the fluid comes out from the side and you aspirate with the central port. It has got an advantage that the central port is directly visible under the microscope. So you don't go on inadvertently catching the capsule in the side port. That's why reverse Simcoe is more popular for using.
Okay, sir. The second question is, how to differentiate between muscle hook and lens expressor?
Lens expressor doesn't have a slight bend which you get it in a muscle hook, because the muscle has to be properly sprayed over and caught over there. So you have a small bend at the total tip that is in a muscle hook. In a lens expressor, it is straight and the length is slightly less. The muscle hook at least has a 10 millimeter spread out length. The lens expressor is somewhere around 8 millimeter with a bulbous end at the end for it. Lens expressor is also nowadays not used commonly. Very rarely it is used.
Okay, sir. Thank you so much. So I think the students are ready with their marks.
Yes.
Akshay, unmute yourself.
Yes, ma'am. In the last session, 10 questions were asked. So out of that, I have scored 14 marks.
Good. Vineet?
15 marks.
How much? How many?
Vineet?
15.
15.
15. Good. Zakira? Your voice is breaking, Zakia.
15.
15.
1-5.
Okay. Yeah. Diksha?
1-3.
Good. Muskan?
Ma'am, 15.
Okay. Prithvi?
14.
14. Priyanka?
16.
Whoa. Arnav? Arnav?
He didn't reply last time also. Okay.
Yeah, but he's there. Okay.
Okay.
Sonali?
Ma'am, 15.
Good. Subhadra?
Totally 13 ma'am, or 30 questions.
It's okay. Our first year, so it's okay.
Just come back, is it, Subhadra?
Yes, sir, she came back.
And
Very bold and smart.
oculoplasty fellow, no?
She is not getting DNB oculoplasty. Okay.
Yes, sir. Students are
I
done.
will mute myself, right? And
Sir, Anil, sir, before leaving, we'll just have a picture with all the students they wanted to have with one of the speakers every time. So,
I am available for you. That's not a problem. I said unmute in the sense it doesn't produce any noise when you are talking.
okay,
Yeah.
fine, sir. Then we'll take it at the end.
Sure.
Ashwin, sir, over to you.
Sir, that was amazing. Now we move on to the second part of today's OSCE, and that's on refraction and pharmacology. And faculty who's going to discuss refraction pharmacology is going to be Dr. Rohan Sawant. Dr. Rohan is joining us from UK. He has taken very recently OSCE for a couple of Royal College exams, and he has been part of some of these academic programs for the last 5 years. And he has a very unique and a meticulous way of teaching the topic that he covers. So over to you, Rohan.
Thank you, sir. Thank you for that introduction. Am I audible to everyone? Thank you. So at the outset, I'd like to thank Santosh sir and Rashmi sir for this opportunity to contribute in my respect. So I'm happy to share my screen now. Okay. Right. So that's the topic given to me today. We will discuss a few OSCEs about optics, refraction, and ophthalmic pharmacology. I would like this to be more interactive, so I'm happy if any of the students or fellow colleagues are happy to answer any questions so that it becomes interactive. So let's begin with the first OSCE.
All the hot seaters, unmute yourself, so 1 minute.
Yeah.
Yes, sir. All the hot seaters, please unmute yourself. Yeah.
Right, so that's the first question in front of you. There's a picture. It has got 2 forcimeter readings. What do you think is the power of these lenses? This question's worth 2 marks. Feel free to answer orally. Right. If you guys are ready, we can get over the answers. Have you managed to write any answers on a sheet of paper? Sorry, I'm not able to hear anyone.
I think this would be a normal OSCE where the students should answer on the microphone.
Yeah. Okay. Right, I think I'll go to the answer slide. So if you look at the first bit at the top, you can see that it shows it could be written in 2 ways. The first way that one could write is a +2 diopter spherical with a +2 diopter cylinder. I put the angle as 45 degrees. Going to the other bit, the bottom bit, I'd write that as a -1 diopter spherical and a +3.25 diopter cylinder, approximately 75 or 80. Let's see what the answer is like. So this is the answer expected. 1 mark for each if you've got that correct. Let's go on to the next part of the first question. Right. So this is a question thrown at the students. By what principle do you think the forcimeter works? Next question is, why is it important to note which surface of the lens is placed against the holder of the forcimeter, for 2 marks? And the last question is, how can the forcimeter be used to determine the amount of prism at any given point incorporated in a lens? Right, so anyone from the audience, I'm happy to take answers. Any volunteers? Right, so the important thing to remember, at least from when I gave my DNB exams, was that although the questions are for 8 marks, you're pressed for time. So you need to write a lot of things within those 5 minutes because you only get 5 minutes. Yes, I'm sorry, I heard someone. Yes, I believe it's Akshay.
So 1 person from live audience have answered as Badel's principle.
Right, so it can also be called as the optometer principle. Let's go on to the next answer key slide. It has basically a collimator and a telescope where the target is moved until a focused image of the target is viewed through the telescope. And the distance through which the target is moved is directly proportional to the dioptric power of the lens, which is kept under the test. So that is the kind of answer. It need not be that elaborate. My answer is a bit longer so that they have a bit more explanation. But as long as they have those keywords like collimator, telescope, and focused image, these things are generally expected as key points to help the examiners mark you. Next question was, why is it important to note that which surface of the lens is placed against the holder? Because forcimeter measures the vertex power of the lens. It is important to mount the glasses against with the back surface against the holder because it measures the back vertex power of the lens. Last question was, how can the forcimeter be measured, used to determine the amount of prism at any given point incorporated within a lens? As it measures the image of a focused target when it is centered will be displaced from the center of the graticule. The cross lines of the graticule are calibrated at 1 prism diopters and the direction of displacement from the center indicates the base of the prism. Right. Just wanted to ask a quick question. Am I going too fast? I can go a bit slower.
No, it's fine, sir.
Thank you. Let's get on to the next OSCE. Okay?
Yeah.
Right. So the next OSCE is again a question. If the far point of a patient is 20 centimeters in front of the eye and the near point is 12.5 centimeters in front again, the questions are, what is the distance refractive correction, the amplitude of accommodation, the near point when varying the distance correction, and the range of accommodation when varying the distance correction. I'm going to give you approximately 2 or 3 minutes to figure it out, and then we can discuss the answers. So the far point is 20 centimeters in front. The near point is also 12.5 centimeters in front. You need to measure the distance refractive correction. That's for 2 marks. Next question is the amplitude of accommodation. Again, 2 marks. Near point when you wear the distance correction, when the patient wears the distance correction, 2 marks. And the range of accommodation when wearing the distance correction.
One of the volunteers can take it up. Maybe.
Yeah.
Amplitude of accommodation would be 3 diopters.
Excellent.
Distance refractive maybe -5. I'm not sure.
-5 is correct because it's 20 centimeters in front. So it will be 1 divided by 0.2 in meters. Good. What about the third question? The near point when wearing the distance correction. So the near refractive correction in this, shall we go to the answers? The near refractive correction here is 1 divided by 12.5 centimeters or 0.125 meters becomes 8 diopters, again in minus. And the distance is -5, so there is a discrepancy of 3. So when it's wearing a -5 for distance, the near point always has a discrepancy of -3. So we have to divide that 3 by 1, comes to 33 centimeters. Am I clear?
No, sir. Can you please repeat?
Yeah, sure. Let's go to the answers. The first point, as you said, is correct, is -5 diopters of myopia, 1 divided by the far point in meters. So far point is in front of the eye, hence it requires a diverging or a minus lens to focus. Accommodation at near point is 8 diopters, as you can see. Relaxed at far point is 5 diopters. So the amplitude of accommodation is the difference in between the two. 8 minus 5, that becomes 3. So when the patient is wearing the distance correction, that is at 5 diopters, he needs at near point 8 diopters. So there is a discrepancy, or there is a difference of 3 diopters for him to be able to read for the near point. So that difference of 3, you have to just divide it by 1 to see that at that point of focus, the patient will be able to read. That will be his new near point when he wears a distance correction. Am I clear now?
Right, sir. Thank you.
Yeah. And the range of accommodation when he's wearing the distance would be the near point, that is, which we have deduced as 33 centimeters. The far point obviously will be infinity. Right. Shall we go on to the next OSCE?
Right, sir.
Yes, sir.
Right. Now, this next OSCE is again a question. So 3 months after an extracapsular cataract surgery, this is the refraction that comes out. Plano with a -10 diopter cylinder at 165 degrees. Now, your task number 1 is to transpose this prescription. Second question is it with the rule or against the rule astigmatism? Would you remove the sutures? Last question is for 4 marks, what are the treatment options or further management options? Let's put it that way. Right, your time starts now. Give yourself 1 or 2 or 3 minutes to gauge, and then the first one should be straightforward. Any volunteers for the first question?
Sir, -10 spherical with the +10 cylindrical at 75 degrees. Sir.
Yes, that is the answer. That's right. So you get 2 marks for that. What do you think about the second question? Is it a with the rule or against the rule? So it's very easy to remember with the rule. Plus at 90 or around 90 is with the rule, plus at 180 is against the rule. So this becomes a with the rule astigmatism, because the vertical meridian has more plus cylindrical power. Would you remove the sutures? Yes, I think you should remove the sutures to see how much of it is settling. Now coming to the management options. The first option, which you have already discussed in the last question, that is suture removal with glasses. That could be one option. What is the next option which you would offer to the patient? You could offer toric contact lenses. This patient who is going to have, if the other eye is not operated, is going to have a significant uneasy cornea. So you should counsel this patient for refractive surgery. In this instance, he might just be benefited with relieving incisions on the steep axis. So I'm just going to give a general answer key. So the first answer is, again, transposed into the cylinder, either deducting or adding 90 with the rule as discussed. And these are the options that you can discuss with the patient. Does anyone have any questions regarding this particular OSCE?
No, sir.
All right. So if you're happy, let's go on to the next OSCE now. Right. Have a look at this picture. Sorry. I'm listening. Go on.
Minified images.
Right. So this is the next question. Carefully look at this picture. First question is 2 things that the patient will complain of. Okay. Each will have 1 mark. So 2 marks for this question. Second, what surgical options can you offer to get rid of these glasses? And what non-surgical options will you offer? Right. What about the first answer? Minification. Someone mentioned minification. That's a good point.
Minification or micropsia.
Yeah. You can mention barrel distortion. That's one of the symptoms that the patient will complain of. Right. Coming to the next question, what surgical options do you think you can offer for this patient? It looks like a very, very high myopic to me. Based on what is shown in the picture.
Refractive surgery, refractive or intraocular refractive surgery.
Good.
Or a combination
good
by optics.
Or a combination of both. That'll fetch you 2 marks. Another, they have asked what non-surgical options will you offer, and they've given more marks for that. Now you need to think.
Contact lens.
Yes. Okay, that is one option. What else can you offer? So to avoid the barrel distortion, you can advise the patient to use smaller lenses, thicker design of the frame. All right. So you can bevel the edges of the lenses. Again, this is all to avoid the distortion. You can use a higher refractive index material to decrease the weight of the glasses, because you can imagine someone wearing these thick lenses, they would benefit by wearing a higher refractive index material. Another important thing to remember, if you can get hold of any of the high myopic prescription glasses, they have a flatter base curve at the front of the glass. Again, all these things are to avoid the barrel distortion. So that's the answer key right there in front of you. Refractive lens, if someone said a combination of both, that is also a very good answer. Combination of refractive surgery and refractive lens exchange, and the other things which we discussed. If you're happy, we can go over to the next OSCE. If anyone wants to copy any answers, I'll wait for a few seconds. Let me know.
So can you explain the concept of flatter base curve?
Sorry? The flatter base curve again is at the front surface, because that becomes the refracting surface, because the light changes from air to glass. And when you have a flatter base curve, there is less distortion, because that becomes the main refracting surface. So if you have a steeper base curve, there will be more distortion around the edges of the glasses. If you have a flatter base curve at the front of the glass, they will have lesser distortion. So that's the idea behind having a flatter base curve at the front of the glass.
Okay.
Right, shall we go on to the next OSCE then? Or if you want to wait, I can wait for a few more seconds. Let me know.
So we can move to next.
Thank you. Right, again. So these are two power cross diagrams which have been placed next to each other. I want you to express these diagrams in plus cylinder form for both of them, minus cylinder form from both of them. So this is a two-part question. First part of the question is 4 marks. Right. Can anyone use the plus cylinder form and tell me the answers of the first and second? Anyone?
So -1 +2 at 135 degrees, sir, for the first one.
-1.
Yeah.
I can't see a -1 there. It's a +1.
-3 and +4 at 135.
-3 diopter spherical and
+4
+4
cylinder
diopter cylindrical at
135.
that is the correct answer because that's a plus cylinder form. What about the next, the second power cross diagram? Try that in a plus cylinder form, in a similar way.
-1.5 sphere plus 3.5
Yeah, -1.5
cylinder
plus, yes,
plus
at
3.5 cylinder at 160.
excellent. Now, can anyone else go on to the minus cylinder form and express these power cross diagrams in a minus cylinder form?
+1 spherical,
yes,
-4 cylinder at 45 degrees.
Excellent. What about the next one?
+2 spherical and -2.5 cylinder at 70 degree.
Excellent. So these are the answers. So plus and minus cylinder. Any questions, or you're happy for me to proceed to the next part?
We can go to the next.
Sure, that's fine. Right. So this is the second part of the question, completely different. So there is a -2 diopter spherical and a +4 diopter cylinder at 100 degrees. The question is, during subjective refraction, the cylinder in this description is reduced by 50% and the axis is rotated to 90 degrees. So what is the resultant prescription if you want to keep the spherical equivalent constant? Right, anyone? So they've asked us to reduce the cylinder by half. Axis is rotated to 90 degrees. They want to keep the spherical equivalent same. What are you going to do? Right, so the trick here is when you're taking out from the cylinder, right? If you're taking away from the cylinder, you have to add half as much sphere. So that is the key for this answer. That's why they asked for the spherical, because you want to keep the spherical equivalent same. Again, rotating the axis of the cylinder has got no effect on spherical equivalent. So the answer for this question would be, you have to keep it, let's go to the cylindrical bit. It would be +2 diopter cylinder, and they have asked us to keep the axis of 90 degrees, just as a trick to see if we do anything different. So we keep that as that, but that, because we have taken away +2 diopters of cylinder, we have to add +1 diopter spherical to a -2. So +1 -2 becomes a -1 diopter spherical. Is that clear?
Yes, sir.
So, all right. Now, the next question is, what is the spherical equivalent?
0.
Sorry?
0.
No, they want to know what the spherical equivalent means in general, regardless of this question.
Okay. It says that
The sphere plus half of the cylinder.
Yes. So it is an average spherical power of a plane or spherocylindrical length, which is power of the sphere plus half the power of the cylinder. Right. Let's go to the answer keys. The first one, just to check if anyone wants to note it down. The top bit is the plus cylinder. Bottom bit is the minus cylinder bit. I'll just hold it for a few seconds, then we can go on to the next answer key. So add half as much sphere and you take away cylinder. That's the whole point in making sure that the spherical equivalent is not affected. And again, it's sphere plus half a cylinder. Let's go to the next OSCE, shall we?
Yes, sir.
Okay. Right. Have a look at this picture. What is this test?
The duochrome test.
Okay, correct. How does this test work? They want to know what is the mechanism of this test.
Chromatic aberration.
They've given it 4 marks. If you just only write chromatic aberration, you're not going to get 4 marks. You might probably get 1 or 2 marks. How does this chromatic aberration work in this case? Third question, very interesting one. Can this test be done on a colorblind patient? And what is a drawback of this test? So can anyone volunteer in telling me how this test, a duochrome test, works? The principle, you know, chromatic aberration. So what is chromatic aberration?
The red is a longer wavelength, so it forms behind the retina, and the green is the shorter wavelength. It will be in front of the retina. So, it's like that if the patient sees red better, then we add minus. And if the patient sees green better, then we add plus.
Okay, that's good. That's a good explanation. So, blue or shorter wavelengths are refracted more, and longer wavelengths are red than longer. So I had a way of remembering this when I used to do I used to
the mnemonic
make a mnemonic. Yeah. Now I used to make a simpler one. Blue bends, B for B. So blue bends more, red bends less. But this test specifically tests the red and green. So the difference in between the red and green zone is approximately 1 diopter. So this test used that bit to get that correction point. Right, coming to the next bit, can this test be used on a colorblind patient?
Yeah, it can be done.
Why? Again, because the principle is chromatic
Gradient
aberration.
of
It's got nothing to do with color discrimination.
photoreceptors.
Yeah, it's got nothing to do with, because patients in colorblind patients generally cannot discriminate colors. This test isn't based on that, so you can still do it. What is the main drawback of this test? There is one drawback for sure.
Used only for a vision which is better than 6/9 or 6/6. It cannot be used for vision which is less than 6/9.
Okay, that is one point. Another important point. If the patient accommodates, this test is not reliable. So that accommodative component is added, and it can create a discrepancy in the result of the test. So the test is most reliable when you add a cycloplegic. So this is the key of what we have discussed. The duochrome test is the name of the test, chromatic aberration, and accommodation, which can reduce the reliability of the test. Hence, it is most reliable when conducted after cycloplegia. I'll stay on this slide for a few more seconds. Whenever you are ready, let's move on to the next OSCE. Right, shall we move on to the next OSCE now?
Yes, sir.
Yeah. Right, again, what is this instrument and how does this instrument work? Straight 3 uses of this instrument and what is the drawback? This is a very typical DMP question. I probably think I had this when I gave my exam. Of course, I can't remember it now because it was more than a decade back, but I definitely remember seeing a picture of this. Yes,
Bosch and Lomb keratometer, sir?
There's no need to mention the company. Even if you say keratometer, that should be fair enough. But yeah, you can mention Bosch and Lomb. That's absolutely fine. How does this work?
Bosch and Lomb keratometry.
Yeah. How does this work? So what does this machine have in between, and how does it
doubling of the image
doubling
and
of
then
image.
Yes. Created by what? So it has 2 prisms which are oriented base to each other. And that's why this produces double images, which are separated by a fixed distance. So these prism double images are lined up, and you have to sharpen and focus, and that calculates the radius or the corneal radius of curvature of the front surface of the cornea. Okay?
Yes, sir.
Now state 3 uses of this instrument. The obvious uses, yeah, go on, anyone. Here you need to just clear,
readings.
Yeah, how do you use? Yeah, use for what? Where do you use keratometry? You need to be a bit
IL
imaginative.
Cataract surgery.
Yes, as a preoperative workup for cataract surgery. Well done. What else?
So
What
can
are you
be
measuring?
used to
You're measuring for corneal astigmatism.
Astigmatism.
Yes, you can also estimate the radius of curvature for contact lens fitting. That's one advantage of using a keratometer. It can also be used to measure surface irregularities, for example, caused by pterygium or caused by keratoconus. And preoperative evaluation in a routine cataract surgery. Okay. What is one drawback of this instrument?
The central 3 mm it actually
Good,
captures.
very good. So it only measures the central 3 millimeters of the curvature of the front or the anterior cornea. So these are the keys for this question.
And the GLB essentially is a total deviation where the FLB is the pattern deviation. So there are various papers saying various things, but by and large, what is ideally
दूसरी वाली चार वो अलग टाइप की मुझे
Sorry. Yeah, I'm keeping it for a few more seconds. If you can go on to the next, let me know. We'll go on to the next slide. Okay.
Yes, sir.
Let's move on, shall we? Thank you. Right. Next question. For the following prescriptions, you need to determine the type and the orientation of astigmatism. That is whether it's a compound myopic with the rule, and you also need to give me the spherical equivalent. Each is for 2 marks. Any volunteers for the first one? What do you think the first prescription, number A, is? What is it?
mixed astigmatism.
Yeah, anyone?
The mixed astigmatism with the rule. First one.
Sorry, mixed astigmatism. Okay, let's transpose this. Transpose the -4 with the +4 diopter cylinder. That becomes a plano with a -4 diopter cylinder at 90, correct?
Yeah.
So because it's plano, it cannot be mixed.
Yeah.
So this is the case of
Plano
simple
cylinder.
myopic astigmatism after transposition. And because if you look at this, if it's plus at 180, so that becomes against the rule astigmatism. What's the spherical equivalent? Sphere plus half cylinder, remember. So it's -4 plus 2. So that comes to -2 diopter. Okay?
Yeah.
Right. Who is going to volunteer for the second one? You should, in your mind, try and transpose and always check. If it's plus minus, after transposition, minus plus, then it's mixed. If it remains minus or if there is plus, then it's not mixed. Right. What do you think? Try and transpose. So
Simple hypermetropic.
Compound.
The +4 diopter
It's a
cylindrical.
compound hypermetropic.
Compound hypermetropic.
Because once you transpose, there is some hyperopia left, and there is plus cylinder as well. Okay. What is the orientation? This is at 135, so it's exactly oblique. You can't write this as with the rule and against the rule because it's exactly at 135, which is just midway between 90 and 180. And the spherical equivalent? Sphere plus half
4.5.
Plus 4.5 diopters. Right, next one. Anybody? Try and transpose and see. Check in your mind. So if you transpose, it becomes
Mixed astigmatism.
Mixed.
yes,
Mixed
good.
Mixed
Mixed astigmatism. Orientation again oblique, 45 degrees, exactly midway between 90 and 0. And the spherical equivalent, sphere plus half cylinder, plus 1.
Plus 1.5.
Last one. Anyone? So there's a minus minus. If you transpose it, compound myopic, sorry, it's a minus prescription. Sure? Any confusion? With the rule, if you transpose, become plus at 90, and the spherical equivalent is minus 2.75. Let's go to the key. Whenever you're ready, let me know. We'll go to the next OSCE. Shall we?
Yes, sir.
Yeah. Okay. Right. One more picture. Now this looks like the opposite. These are thick lenses. The question is, name 2 things a person wearing these glasses would complain of. The important thing to remember and differentiate this from the earlier picture was they only showed a single glass. Here they are showing both lenses.
Patient will have roving rings scotoma, and
Yes,
pincushion effect.
Excellent.
Because of high plus power.
Yes, great. You can also mention heavy glasses. They look heavy. Magnification of images. Now, enumerate 3 ocular causes associated with using these glasses. Why is this patient wearing these glasses? What could be wrong with him? So one thing that comes to the mind straight away is he's probably had surgeries and it's left aphakic. Yeah? Or he's a born high hypermetrop. Or another interesting thing is he could have a lens dislocation, either traumatic or non-traumatic, where he's more usefully using the aphakic portion of his non-traumatic lens dislocation. Does anything come to your mind? Anyway, never mind. Now, what are the other options apart from glasses? Yeah, good. Marfans is a good answer. So, not every Marfans is treated surgically, remember. First, as long as the patient is comfortable and if he's using the aphakic portion of his dislocated lens and it's controlling that with glasses, you need not operate a Marfans subluxated lens or dislocated lens anyway. What are the other options apart from glasses would you advise for this patient?
If the patient has undergone surgery, so secondary IOL can be implanted.
Good.
Scleral fixated IOL.
3 marks. So mention 3 things you will do. You'll counsel this patient for secondary IOL surgery. Good. A better, simple, practical option apart from glasses, offer contact lenses to the patient if the patient is tolerating them. If the patient is a born high hypermetrop, you can also counsel the patient for a hyperopic LASIK. Can you not? So that also becomes an option. Okay, so that's the key to these to this question.
Hyperopic LASIK can be done up to what power?
Ah, that's an interesting question. Oh, you caught me there. I think as far as I remember, no, I'll have to go back and read that. But I think there is a limit to that. You are right.
Okay.
Shall we go on to the next question, shall we?
Yes, sir.
Yeah. Now, just thankfully, I don't know if you're thanking me, but it's the last question of optics and refraction. Right. Have a look at this picture. What is this picture showing you?
Showing inferior steepening.
Good. Good.
Thanks.
Yeah. There's also, you can see here, there's the downward displacement of the apex. Correct? So how does this test work? What is this? They haven't asked what is this test, but they've asked how does this test work?
There is a shine flag principle by the pentacam.
So what does this use? This uses the reflected images of a placido disc of concentric circles, which is painted inside a concavity. So these enable these topography instruments to produce a detailed map of the shape of the entire outer corneal surface. What is the most likely diagnosis? What do you think this patient has?
Keratoconus.
Or could be pellucid marginal
marginal
degeneration.
Yeah. What is the most likely? If you mention 1 instead of 2, will you go for keratoconus or will you go for pellucid?
Pellucid.
Name 3 physical signs which will be associated, assuming that this is a keratoconus, on slit lamp examination.
Munson sign, sir.
Yeah, good.
Vogue striae and Fleischer ring.
Fleischer ring, excellent. So that's fine. Okay, so that's the key. Now this, I've just given an overview of how optics and refraction questions can be approached. So you can try and practice based on similar lines. with different either modalities, with different ways of doing refraction, different retinoscopies. I think giving surgical a clinical examination retinoscopy videos, I thought maybe it might be out of domain, but I have definitely seen them keeping videos. So they might still keep a video of retinoscopy reflex and tell you to transpose and to write the final description. If you're happy, we can go to the next part of my talk, which is ophthalmic pharmacology.
Yes.
Yeah, right. Look at this picture. So some of these questions are direct pharmacology questions. Some of these are interpretation of pharmacology. And some of these questions are systemic medications, which comes under the banner of pharmacology, causing ocular side effects. So anyone, can you tell me what is the diagnosis?
Cornea verticillata.
Yeah, or vortex keratopathy. Good. Now that's a bit. Yeah. What are 3 drugs which are known to cause this condition? Because remember, this is yeah, good.
Chloroquine and phenothiazine also.
Yeah, indomethacin is also another drug. Tamoxifen can sometimes cause this. Chlorpromazine. So once you know these drugs, the next question again is related to that. What medical history will you ask?
Cardiac disease.
So for example, if there's someone is taking tamoxifen, yeah, you'll ask a history of breast cancer, likely female. Amiodarone, you'll ask for a history of cardiac disease. The patient is taking chloroquine, you ask for a history of connective tissue disease. The patient is taking chlorpromazine, you'll ask for a history of psychiatric conditions. And endomethacin, very commonly used for arthritis, can also cause this. There's one main systemic association with this. Can anyone tell me what that might be?
Fabry's disease.
Great. What is the treatment? When you see this, what are you going to offer? What are you going to tell the patient?
Discontinuation of the drug.
Stopping the drug.
Alternative.
Not necessarily.
Alternative drug could be given in the same class.
This actually does not need any treatment. Patients who can remain on, so if the patient is on amiodarone, you can't tell the patient to be on amiodarone because he has this finding. It is just an association. It actually very hardly causes any symptoms to the patient. If the patient is symptomatic, of course, you stop the medication, but otherwise there's no treatment needed for this. Okay, so that's the answer key. The same discussion of what we had right now. Shall we go to the next slide?
Yes, sir.
Yes, sir.
Okay. Right. So they have given a nice slit lamp photograph of what looks like a
Posterior subcapsular
cataract, but they're not interested in that. They think this posterior subcapsular cataract is because this patient is taking steroids. They want you to tell them what 3 systemic side effects of steroids can anyone have.
It can
osteoporosis, hyperglycemia,
decrease in the immunity and decrease in immunity cytokine.
Gastric ulcer, osteoporosis, hypertension, hypoglycemia, someone said good. It can also cause adrenal suppression. Next question, write any 2 points you will ask in the history before starting someone on systemic steroids. Again, it's previously covered in the earlier question.
Peptic ulcer and tuberculosis.
Yeah, great. History of tuberculosis. You can also ask history of varicella, pre-existing diabetes, history of hypertension. Any 2 symptoms that the patient will complain regarding this picture in particular. What are the 2 main symptoms that the patient will present? Glare. Yeah, blurry vision. Yeah, glare is a better word than photophobia. Yeah, excellent. Name any 2 other ocular side effects.
Glaucoma and cataract.
Topical steroid will lead to
topicals will cause increased intraocular pressure. Steroids, long-term steroids are known to cause increased intracranial pressure, which might be associated with papilledema if you want to stretch it further.
Yes, sir.
Yeah, so that's the key. So if they ask any 3 systemic side effects, and if you know 4, you know 5, write them. You never know what can catch their eye. They might be looking for something in the key, And if that's not there in your answer, they might, in spite of writing 3, they might not give you the whole mark for that. Okay, shall we go to the next question then? Or if you want to wait for a few more seconds, I'm happy to wait.
Next question.
Thank you. Right, so they're given a picture of a bottle of Xalatan. And now they're asking, what is the mechanism of action?
Prostaglandin analog.
Ocular. Yeah, it's a prostaglandin analog. What does it do? How does it act? Sorry, I can't. All of you are talking at the same
It
time. Yeah.
increases the uveoscleral outflow by
Excellent.
causing
Yeah.
the extracellular matrix remodeling.
Yeah, good. It targets the NFP receptor on the ciliary muscle. Increased uveoscleral outflow should be enough. 2 ocular side effects.
Hyperpigmentation. Heterochromia iritis.
Yeah.
Hyperpigmentation and hypertrichosis.
Periocular pigmentation is also increased.
Yes, that's correct. Yeah, that's right. 2 systemic side effects. Someone with Xalatan, you put them on Xalatan and they'll come back to your clinic after a few weeks and saying, oh, I'm getting a terrible headache, doctor. Is this because of the medicine? Sometimes in pre-existing migraine people, it can precipitate migraine. It can, on odd occasions, textbook described, can cause myalgia, skin rash, mild upper respiratory tract symptoms because it, as you know, drains through the nasal passage. 2 relative contraindications where you would not use
Herpes
Xalatan.
keratitis, and uveitis.
Yeah, anti-uveitis, correct. Excellent. So that's the answer key. Correctly mentioned, increased uveoscleral outflow, increased pigmentation of the iris and eyelid skin, eyelash growth, commonly causes conjunctival hyperemia as well. And then with the systemic. Next question, shall we?
Yes, sir.
Yeah. Right. They've shown you a picture of, I hope you can see that, Lucentis. They want to know what's the mechanism of action. 3
Anti-VEGF agent.
Yes.
So
How
it
does
acts
it
against
act?
the VEGF.
Yes. And does what? You just, if you write anti-VEGF agent acts against VEGF, you probably get 1 mark. We want 2 marks here. So we need to at least write something more than that. So what is
All isoforms of
yeah? What is it? It's ranibizumab. It's a humanized monoclonal antibody which binds to all isoforms of VEGF. Yeah, reduces vascular hypopermeability, leads to resolution of intraretinal, subretinal fluid, tries to restore normal architecture. That you can avoid. Even if you write intraretinal, subretinal fluid resolution, that's more than enough. 3 ocular indications commonly used for
Diabetic macular edema, CRVO with macular edema.
Neovascular age-related macular degeneration, myopia-associated CNV could be an answer. Right, any 2 clinical trials associated. So I want you, forget about these 2 marks. I want you to tell me 2 clinical trials which used for ARMD, 2 clinical trials for diabetic macular edema, and 2 clinical trials for retinal vein occlusion. And if someone can tell me the name of the trial for
Anchor and
So for
Marina.
ARMD, it is Marina, Anchor, and CAT trial and Ivan trial.
You're good. What about diabetic macular edema? They did 2 studies, RISE and RIDE.
DRCR.net.
So we have DRCR protocols, protocol S, T, and U.
RISE and RIDE are 2 names which come to my mind. Of course, it will come in the answer key as well. Cruise and Bravo is for retinal vein occlusion. Radiance was a study which was for myopic associated CNV. Next question, 2 other alternate drugs which could be used.
Bevacizumab,
Pegartinib.
aflibercept.
Yeah, aflibercept, Eylea, bevacizumab, Avastin. You can also use the dexamethasone plant specifically used for diabetic macular edema and retinal vein occlusion, Ozurdex. Right, shall we go to the next question then?
Yes, sir.
Okay. So they have given you not a pretty looking picture on your right, saying the cataract surgery patient presents to your clinic with these signs 3 days after cataract surgery. You suspect endophthalmitis. The first question is, what are the 2 most common organisms likely to cause this? I'm going a bit beyond pharmacology into microbiology. Yes, go on.
Staphylococcus epidermidis.
Yes, Staphylococcus epidermidis is great. What else? Staphylococcus aureus can also cause.
Yes.
Sometimes Streptococcus species.
Streptococcus.
Yeah, good. So ESCR did a study, and they're asking what is the single most effective preoperative step proven to be protective against postoperative endophthalmitis. They worded the question very well.
Installation of the betadine in the fornix.
Sorry?
Installation of the betadine eye drops in the fornix.
Correct. Povidone iodine, if used preoperatively, it was studied to be the single most effective preoperative step to avoid or protect against, not avoid completely. Right. 3 intravitreal drugs used commonly to treat this condition.
Vancomycin, septum.
Yes.
Ceftazidime would be 2.25 milligram in 0.05, 0.1 ml. Vancomycin would be 1 milligram in 0.1 ml.
Yes, and any other drug? There were 3 drugs.
Imipanam.
Yeah, go for amikacin probably. Yeah, 0.4 milligrams in 0.1 ml. And they are probably, in the next question, there are 3 topical fortified drugs used and their doses.
Tobramycin 1.3%.
Okay.
Vancomycin 5%. Cefazolin 5%.
Is it 5% cafeterism? Okay. These are the keys to this answer. Right, happy? If you're happy, we can go to the next one.
Yes, sir.
Sure. Right. Given pictures of what looks like provisc and viscoat. They're asking you, how will you classify OVDs with examples of each? What are the different classes?
Dispersive or viscoadaptive. And cohesive.
Examples of cohesive?
Cohesive is Helon GV.
Sodium hyaluronate.
Good. Which is sodium hyaluronate.
Provisc is also cohesive.
Dispersive is the normal
HPMC.
iWhisk that we use.
Yeah. Viscoat is also dispersive. Yeah. Good.
Viscoadaptive is Helon 5.
Helon.
That is Helon 5.
Yeah. So next question is, what is soft shell?
It is a technique described by Arshinov, which says that they put the dispersive, which covers the corneal endothelium, and the cohesive covers the central part.
Brilliant. And name 2 uses of at least 2 types of OVDs. So where will you use a cohesive? Where will you use a dispersive?
So during cataract surgery, during Capsulorhexis, we use cohesive. And before IOL insertion also we use cohesive. But when we are doing chopping or anything, we can use a viscodispersive agent to protect the corneal endothelium.
Right. If you have a posterior capsular rupture, you can plug with a dispersive, plus push the vitreous back with the dispersive into the posterior chamber and temporarily plug the capsular defect. Sometimes you can also use a cohesive if your rhexis is trying to run away. Inject the cohesive to flatten the anterior capsule so that you salvage a runaway rhexis. And if your pupil is not dilating well, just inject the cohesive so it will try to mechanically induce mydriasis. So that is the key to these questions. Correctly said, cohesive, dispersive, adaptive. Soft shell, Arshinov, someone mentioned, very well done. Okay, so whenever you're ready, let me know. We'll go on to the next question.
Yes, sir, next.
Right, this is a very interesting one. One of my favorites because I actually encountered this patient in one of my practice. So a patient with migraine comes to you with sudden onset blurry vision. She mentions that she has recently started on a new drug by her neurologist. Carefully look at this. What is the most likely drug prescribed?
Topiramate.
That's correct. Yeah. How does it act? What is the mechanism of action? How does it act? What does it cause?
Ciliary effusion.
Yes, it causes ciliocoroidal effusion, causes an acute angle with induced myopia. Yeah. Are there any other classes of drugs which could result in similar signs apart from topiramate? Can you think of any other names?
Sulfonamides.
Great. You should think about sulfur drugs, also including
like acetazolamide is one example of sulfonamides.
Great. Great. How would you treat this patient, and what is the prognosis?
Stop the drug. Prognosis.
Yeah, great. You stop the offending drug. Then what do you do? You can see that the anterior chamber is very, very shallow. What are you going to do about it? Anyone? Patient comes to you with this finding, pressures of 30, 32, 35. You tell them to stop the topiramate. What is the next thing you're going to do? Stop the topiramate.
So use Mydriatics.
Mydriatics, okay. The angle is already compromised.
The laser
so use of Mydriatic.
I think it will resolve on its own on stopping
The trick here, what they want to not write is laser peripheral iridotomy, because let's go stepwise. So you treat this patient, basically stop the drug, control the IOP medically. Instead of Mydriatics, use cycloplegics. So that's what they're expecting. So use cycloplegics. Follow the patient every day. The intraocular pressure generally improves within 2 to 3 days. The myopia improves within a week. There's no need for a laser PI because there is no pupillary block here. There is ciliochoroidal effusion. So if you take care of that, PI does not have any function. So it's not indicated. And the prognosis is very good because generally when you drop the medicine, remember to let the neurologist know that you should replace the topiramate with another drug. Otherwise, you'll tell the patient to stop. 15 days later, patient goes to the neurologist. Neurologist will say, "Arey, you stop the medication. Your headaches come back again. You got migraine. Restart it again," and she'll end up again in your clinic. So that's the key to this question. Correctly mentioned sulfonamides, including acetazolamide. So peripheral iridotomy is not indicated in this condition because there is no pupillary block. Okay, if you're happy, we can move on to the next slide.
So there is one question regarding this.
Yes.
Why cycloplegic? Why not Mydriatics? And if we are using cycloplegic, then which one will you prefer, and what will be the dose?
Well, the mechanism is cerochoroidal effusion, so the ciliary body is actually turning forward. If I use the cycloplegic, it will turn back, and then it will create the space, and the pressure will be relieved. Commonly used cycloplegics like cyclopentolate you can use, for example.
And how many times?
2 or 3 times a day.
For how many days?
You just give it till you see that the anterior chamber is deepening. Even if you do it for short term, like for 2 or 3 days, that's more than enough. So then it does its job basically. You don't need it for long term.
Okay, sir. Thank you. We can go ahead with the next. Yes.
So let's go on to the next question then. Again, your rheumatologist has referred this patient to you for opinion following treatment of rheumatoid arthritis with a drug for 6 years. So what do you think is happening?
Chloroquine.
Hydroxychloroquine. Yeah. So that's a very straightforward diagnosis. Is either taking chloroquine or hydroxychloroquine for a long time. What is the mechanism of action for this particular finding that you see in the eye? What is happening here? So what do these drugs do? What are they doing?
The chloroquine is melanotropic, so it gets deposited in the RP and the choroid.
Yeah.
So then later on, it causes atrophy of the ISOS junction and gradually.
Of the very good answer. That's a very good answer. Disruption of photoreceptors and RP. Excellent. So, what is the initial screening protocol? So this patient has come quite late to you, can't do much for it. But if your rheumatologist refers to your patient saying that, oh, I'm going to start this gentleman or lady on chloroquine, how are you going to initially screen or say that I put this patient already on chloroquine for 6 months and he send you to evaluate? What are you going to do?
Baseline visual fields and OCT.
Yes, visual acuity. What else can you do?
Visual fields, OCT.
OCT, okay. What else?
Multifocal ERC and fields.
Someone mentioned fields. What specific fields will you ask? I heard someone saying
red and green colors.
The
right.
multifocal ERC.
Multifocal ERC. I think you work at a tertiary center probably. Okay. So vision is correct. Vision is good. I would perform a 10-2 visual field test. Look for central macular function, fundus examination, of course. You can also do the Amsler grid, the red on black one. That again tests the central macular function. What advice will you give to the rheumatologist?
Change the group of drugs.
You're seeing this and you're seeing this finding. He has sent you this patient. Now, what are you going to tell your rheumatologist? You probably tell him to stop the medication. Not that it's not going to make a difference in his eyes because it's mostly irreversible. And you'll advise to stop the drug and replace it with something else. Right. So that's the key to this question.
I think there are two more things I would like to add here. Is that
yes, sir.
Since it's a bullseye maculopathy, it's a macula which is involved. So color vision also will form the part of the screening protocol.
Yes, I agree with you.
And because of HCQ in the news, because of the COVID prophylaxis and treatment, we should also know as to at what threshold or what's the dose which would generally lead to such an advanced retina. Remember that the buffer for safety, especially for hydroxychloroquine, is quite high. Unless you take this medicine for 5 years, which a lot of these people who have arthritis would require, generally the retinal toxicity will not be seen prescribed for 12 or 14 weeks for COVID.
Correct. Correct. Excellent. Very good point. Okay, shall we go on to the next slide then?
Yes, sir.
Right. So you're treating an angle closure patient with this drug shown in the picture. Again, pharmacological question, what is the mechanism of action? How does this work?
Carbonic anhydrase.
Carbonic anhydrase
inhibitor, which decreases the aqueous production.
So reduces the aqueous production. Where does it act? Where is this carbonic anhydrase enzyme present? It's present in the non-pigmented ciliary epithelium. So that's how it reduces the aqueous production. Name two ocular side effects of taking this. Any ocular side effects? We just discussed it. We can take a cue from the last couple of slides back. We discussed something. Yeah, it can cause choroidal effusion. Yeah, as we saw with topiramate, just two slides back, and subsequent angle closure. Any systemic side effects? Most important.
Nausea,
hypokalemia.
Hypokalemia is something which they would expect. Yeah, that's right. Hypokalemia is correct.
Paresthesia.
Nausea, right? Very good. What else?
Gastrointestinal disturbances.
Okay, great. Anything else that you can think of?
Sulfonamide reactions.
Yes, good.
Bone marrow suppression and other sulfonamide related side effects.
Wow, excellent. Name one contraindication now where you are not supposed to use this and one harmful drug interaction. Yes,
Sulfur drug allergy.
Yes, anything else? More likely a medical condition where you would not use this drug. If someone's got liver failure or if there's renal calculi or chronic kidney disease, you would not use this. Any harmful drug interaction? You're telling the patient, yeah, I'm going to give you Diamox, there's angle closure. Are you taking any medications? The patient tells you, oh, I'm taking furosemide already. You should remember that if you take acetazolamide with thiazide diuretics, it may exacerbate the hypokalemia. It may cause profound hypokalemia. They're already losing the potassium on thiazide diuretics. So that's the key to this question. I'll stay on this slide for a few seconds. You let me know when you're happy to proceed and I'll proceed.
Yes, sir, we can proceed.
Thank you. I was coming to my last question. All right, so look at this picture. You already know what it is. It's in the question again. So they're not interested in diagnosing the condition that is not, let's say, the dose. Yeah.
Apraclonidine 0.5%
So
and
they want two
cocaine
drugs.
4%.
Yeah.
Apraclonidine 0.5%, cocaine 4%
Yes.
could be used for just seeing whether Horner's is present. Then to differentiate whether it is preganglionic or postganglionic, we use hydroxyamphetamine or phenylephrine.
Great. So how does, coming to the first question, you're diagnosing Horner's with apraclonidine 0.5 or 1%. How does it work? What is the mechanism of action? Because they've asked the mechanism of action in the question. If you look at the question, it's for 4 marks.
Apraclonidine mainly increases the sympathetic activity by acting on alpha-2 receptors.
Alpha 1, I guess.
Alpha
2.
In
Alpha
this,
2,
there is
okay.
denervation hypersensitivity in Horner's. So it will dilate a Horner pupil, like apraclonidine will dilate a Horner pupil because of denervation hypersensitivity.
Okay, okay.
But
what about
cocaine
What
will
does
dilate
cocaine
a normal pupil because
why doesn't
cocaine
Horner's pupil not dilate? Yeah, go on. Sorry, I interrupted you. Sorry. Why does the Horner's pupil don't dilate? Yeah.
uptake. It prevents the uptake of the adrenaline.
Noradrenaline at postganglionic.
Yes. So
it causes
it acts
dilation.
on a normal pupil, and if in a Horner pupil there is no adrenaline already because of the so it won't if there is no adrenaline, so it will not act.
Excellent, excellent answer. What about differentiating in between pre and post ganglionic Horner's?
So we use
Again, with the mechanism of
hydroxyamphetamine
action.
or we can use phenylephrine.
Yes.
Hydroxyamphetamine or phenylephrine.
Yes. How does
now,
hydroxyamphetamine work?
phenylephrine, so again, it acts on sympathetic thing. So in case of because of denervation hypersensitivity, in case of a postganglionic lesion, it will dilate the pupil.
Correct.
But
Correct.
hydroxyamphetamine basically causes the release of the adrenaline from the neuron, and then it acts. Now, in a postganglionic lesion, there is no adrenaline, so it won't dilate a postganglionic lesion, but it will dilate a
third
normal
order,
pupil or a preganglionic lesion.
Yeah, excellent, excellent answer. So these are the same things described in these questions, so that's absolutely fine. So that brings me to the end of my topic. Thank you, thanks a lot. I hope that was useful for examinations coming in the future. Thank you.
Sir, there are 2 questions for you.
Yes.
Yes, sir. One is related to that bullseye case.
Yes.
What are the latest doses duration for chloroquine and hydroxychloroquine?
So in hydroxychloroquine, initially they said that it's 6.5 milligrams per kilogram, but now they have reduced it down to 5.
Duration, sir, for how
Is there
long?
any duration for how many years, like 2 years or 3 years? And what is the cumulative dose?
Now I am in the UK.
In Kansky, it was written 1,000 grams of the cumulative dose, but the latest guidelines, I don't know.
So the latest guidelines which we follow over here has got nothing to do with the cumulative dose. At any given point of time, if the patient is on for at least 3 years on 5 milligrams per kilogram or more than 5 milligrams per kilogram per day of hydroxychloroquine, chloroquine is not used a lot in the UK anymore. So the main guidelines of hydroxychloroquine. So then you suspect that the patient
most
is
of the
likely to
MCQs,
develop.
they ask whether daily dose is more important or cumulative dose is more important for toxicity.
Yeah, I know. I've read that MCQ.
So what, like, I don't know exactly about it, like daily dose or cumulative dose.
It is a daily dose. But, 1 gram. I mean, people with rheumatoid arthritis or silly, they are on chloroquine for years together. And bullseye macropathy is not that common. I mean, when it happens, it's fascinating, but it's not that everybody who is on this treatment for 3 4 years develop the problem. So I don't think cumulative dose would be that important, but obviously, I don't know whether Dr. Kulkarni can repeat that or Santosh or Rohan?
They had the regulation about cumulative dose previously, but for the new one, for the new guideline, they have taken it off. So I guess they are more towards saying that daily dose is more important.
I agree with Dr. Rohan. The cumulative dose concept was there earlier, but nowadays it is more important about the daily doses. And we have even seen people who have started with HCQ for just about 8 to 10 days, also developing side effects and sometimes the pigmentation. So it's not necessary that you calculate the cumulative dose itself. It's better that if you get some changes or some symptoms or even signs, then you need to modify the doses.
It's a very interesting point that sir puts across, because the patient which I was mentioning about topiramate, she developed this with her first dose of topiramate. So it's not necessary that you need to be on topiramate for a long time. Right. She just took it once and she came to my clinic with this finding. So whatever sir says, also, I mean, we have guidelines saying that things can change over a period of time, but sometimes we get things which are quite acute as well.
Thank you, sir. Anil, sir, we have 3 questions for you. Anil, sir, please unmute yourself.
Sure.
Yeah. The first question is, what is the difference between Kerrison and the Setley's bone punch?
See, the difference basically is that Setley's bone punch is being used commonly. It has got a smaller tip, so it can pass it through a simple opening through the lamina papyracea. It is easier to operate with Setley's bone punch, and it is slightly sturdier.
Okay, sir. The second question is there any special name for the muscle hook?
I am not aware, because we call it only strabismus hook, because there will be a lot of names which can be put up by many people, but it's not acceptable at this stage. We also call it as strabismus hook only.
And the third question is, when we are looking on a slide or a picture, how can we make a difference between Vannas seizure and the Westcott seizure?
Westcott seizure is quite big. Vannas seizure is that way quite small. And the blades of the Westcott seizure are almost, you can compare it with the body. They are quite huge. While the blades of the Vannas seizures are almost tiny. So that is how you can differentiate. And Westcott's has got a blunt end. Vannas usually can be sharp or it can be blunt also. But the actual blade size compared to the entire seizure is very small.
Okay, sir.
Quite delicate also, yes.
Thank you, sir. So there is a question which Rohan sir has already answered there. What is the daily dose of hydroxychloroquine? Is it 400 milligram or 1 gram per day? Dr. Rohan sir has said that in UK they give 400 milligram per day max. Rashmin sir, Santosh sir, what is in India?
For what is the indication? If for COVID prophylaxis, it's 400 milligram per day.
Bullseye maculopathy.
Mainly because there's a lot of autoimmune conditions over here. They generally do not tend to, at least I have not seen that in my practice yet, anyone go beyond 400 milligrams per day, which is a standardized norm.
Okay, sir. Rashmin sir, over to you.
Right. So thank you so much. Thank you, Dr. Kulkarni. Thank you, Rohan. I think some of the often asked questions, but then collected in a lot of our training, and you have covered it beautifully within an hour. And I'm sure that all the participants and attendees have benefited by it. Thank you so much.
Sir, wait. Hot seaters, please come. You can have a picture now. Don't message me for this. I'll request my co-fellows also. Harika, ma'am, please come.
In our instrument round, it is Dr. Priyanka which has scored the maximum numbers.
Yes, sir. So any special
Dr.
prize?
And then Dr. Sonali.
Them?
So
any special prize for them, sir?
Yeah. We will ask Dr. Rashmin, he's the host. Special appreciation from the examiner and prize from Dr. Rashmin.
Akshay is there. Vineet, are you there? Yeah, Vineet is there. Zakia? I can't see you. Diksha, Muskan, yeah, you're there. Prithvi, Priyanka, Arnav, Sonali is there. Subhadra, you can join. Mritika, ma'am, please come. Sunil ji, please take a picture. Okay, so we'll do thumbs up.
Yep.
Okay. So thank you, hot seaters. Thank you, panelists. Thank you, sir. Sunil ji, I hope you're taking the picture. My one hand is.
Give me a minute. Give me a minute.
Yeah. Done?
Done.
No, just wait a second.
Done? Sunil ji, done?
Done.
Yeah. Thank you.
Thank you.
Thank you, sir. Thank you so much.
Thank you, sir.
Join us next week, next Wednesday actually, for cornea and ocular microbiology.
Yes, sir. Thank you so much.
Okay.
Thank you, hot seaters.
Thank you, ma'am.
Thank you, Anil sir. Thank you.
Thank you.